Welcome to Policy Unpacked, a podcast by the Global Policy Network where we explore policies shaping our world. I'm Stephen Riley, Deputy Regional Chief Pharmacist at NHS England North West and a GPN Associate. I'm really excited to host this series unpacking policy of medicines in the NHS 10-year plan. In this episode, I'm joined by Uzo Ibechukwu, Chief Pharmacist at the Royal United Hospitals Bath. He's also led pharmacy services across Bath, Swindon and Wiltshire as an ICS Chief Pharmacist. Hi Uzo, it's great to have you with us today.
Thanks for having me.
Really appreciate you being with us. It's fantastic, thank you. So just a little bit about yourself. So could you explain to our listeners what your role is and how you got into the role?
I'm happy to. So as you already described, I'm the Director of Pharmacy and Chief Pharmacist in RUH Bath. My career has followed a fairly similar path to most who end up in these roles. So I started out in community pharmacy, which taught me many of the things that I put in place and how I see the world today. I worked in primary care at various points. And then we came into the acute sector back in 2011. I've worked many of the, if you like, offbeat posts, but have also been supported to go into more corporate roles as well. Like at one point in my career, I was a business manager for a medical director. And what I found, and I think what the biggest jumps in my understanding of the work we have to do have very much been when I've been focused on other areas that might not necessarily be pharmacy. And so, I've also been supported to do non-pharmacy related training like Masters in Health Policy and Leadership Development in more recent years. So as I saw somewhere quite recently, it's never been about the focus on the position, more about focus on building the skills to do or support or lead what needs to be done. And so I've been quite lucky to be supported throughout my career. In terms of my workforce, passion for workforce, that's just always been the way, and that's sort of the prism through which I see the world. So in terms of what my role is, as I mentioned, Chief Pharmacist, I'm the accountable lead for all things to do with medicines in an acute NHS trust. But the role has evolved, and it's very, very much more about system working now. Collaboration across professions, collaboration across sectors, system redesign, to sort of try to start addressing the bigger challenges that we see coming towards us.
That's great, and it's really great to, as you say, it's more about developing the skills, the abilities, experience than to do the leadership rather than focus on the role itself. It's a really great perspective to have. I think it's really fantastic. And what would you see as the biggest challenges facing the hospital sector today?
There are some big challenges. What would I need to qualify this with, this is the prism through which I view the world. I view the world through how your experiences affect how you lead and how your experiences and culture drive change. So I think that in that the biggest challenge I see is our workforce, and not just the numbers, which we know are growing less and less and less for, if you like, the population health challenges we face, but how equipped we are in terms of capability, development, pipeline development, and, if you like, the roles that the systems into which we're designing these. So I think there's a bit of a misalignment between all of those, and there's a misalignment across many of our priorities across sectors. I know lots of excellent work is being done to align these things, but I think our workforce and how we prepare them and how well aligned we are to system priorities are probably our biggest challenge, if I had to put it that way.
No, I think that's a really good key point. And I think, to be fair, that would chime with a lot of colleagues in other sectors. I think workforce has certainly come up through the series of some significant challenges across our sector. Just looking ahead then, what are your strategic priorities for hospital pharmacy over the next decade?
Well, again, a really big one. I am only one director of pharmacy and one acute chief in one acute trust, which is not even a particularly big one. So I will speak for where we are. And again, it's very, very much how do we how do we right fit our department and our services and our people, the people we care for, the people who we work with, really to face the challenges that are coming our way. Because I think the one guarantee that there will be is that there will be change. So how do we people to innovate and move forward and come to work and be themselves in all this constant change? How do we, so you mentioned 10 years. What will the world look like in 10 years? Will the skill sets that we're developing now be the right one for the world in 10 years? I have my views on that. I think the 10-year plan as a document of intent really should spell out exactly what our priorities should be. But in terms of hospital pharmacy and to be honest, acute care more generally, I feel that we're in a bit of a strange position because we're almost being asked to design systems or collaborating systems in which we will have a lot less influence. I mean, when I say we in this acute space will have a lot less influence than we've ever had before. And while many people are in that place and appreciate the need to do so, some maybe aren't. And so it'll take some time to move from competition into collaboration. So I think we need to be more forceful about that, and what I hope is that, if you like, the contractual frameworks that make change happen follow quickly. So in terms of strategic priorities for hospital pharmacy, how do we supply medicines? How do we supply medicines care to patients closer to their homes, out of this acute space? How do we prepare our people and our services really to do more work outside of this space? Because thankfully, most people never see the inside of a hospital. We might think the numbers here are huge, but they don't. But we have a lot of expertise in here. How do we, if you like, use that expertise better in other spaces?
That's a very good key point. And you mentioned, obviously, again, the change that's coming and being ready for change and how we be part of that and look at it positively. So what are your ambitions then in light of the 10-year plan for the hospital sector?
Again, as I said, the 10-year plan absolutely says the right thing. Nothing there should be controversial. And to be honest, anyone who had a forward-thinking strategy should already be starting to think in line with those things. I think, though, that our strength, and this has always been the case for pharmacy across the different sectors, that our strength comes in working together and being able to more successfully tell that patient story right across the board. So, I think the ambitions will become better in aligning our training and development and the services that we're trying to provide, in utilizing or supporting our workforces to work across sectors more easily. So things like, how do you get better contracts so that, I don't know, or contractual frameworks so that people can just move with the patient, move with the healthcare. Things like shifting towards community-based care. I think we all know that that's the right way to go. How do we make sure that we have the people and the spirit of collaboration to be willing to give up? Give up is the wrong thing, but be willing to deploy our capabilities for the greater good when we might not get the glory, if you like. So I talk a lot about collaboration. I think the things around digital health infrastructure, those are obvious. Everybody knows we need a better digital health infrastructure across the different sectors. They're very clear haves and have-nots. But even in that space, I look at when I look at preparedness, I think, do we have the digital literacy, the people who know their way around informatics, automation, AI? Do we have them in the numbers that we need to cope with this future coming? I don't think we do. So we need to start looking at things right from our curriculum. Is our undergrad curriculum fit for purpose? Because in effect, the people going through now will be our leaders in 10 years. Are we preparing them now? I hope that touches on some of the things, but everything, medicine, safety, workforce development, these are all obvious things, aren't they?
To be fair, yeah, I agree, but it's really useful insight to that, and I think and it's what this week you touched on collaboration, how pharmacy workforce can work differently. So I think what role do you think hospital pharmacists will play in multidisciplinary teams under the new reforms and changes?
I'll start with, I suppose, a note of caution that they can be anything, but it's going to what hospital pharmacists and pharmacy technicians will determine on our ability to build relationships, on our ability to really tell the story of what we bring to the table. Because up and down the country, whatever fantastic thing you want to see a pharmacist, a pharmacy technician doing, there's probably an example of it somewhere in the country. Why is that not duplicated? And that has a lot to do with how we deliver our services, what our ability to influence in our local environment is. So yeah, I fully think that for hospital, I'm not even going to say hospital pharmacists. I'm going to say pharmacists should be fully embedded in multidisciplinary teams. In terms of, yes, we know the prescribing capability that pharmacists will have on qualification soon, but even non-prescribing pharmacists like myself will bring something to the table. And it's less about your knowledge, less about you telling everyone what's right and wrong, and more about how you're able to influence change and work with teams to redesign how we provide services. Because I think the key shift that is happening already is that we're all recognizing that the problem is not that we're not doing enough of everything we've done up to now. The problem is that we need to work differently. Or if you like, the challenge is that we need to work differently. And knowledge alone doesn't mean that you're going to be an effective part of that. You need to have the tools to be able to redesign that change. So, I think, yes, we as pharmacists should be more embedded in multidisciplinary teams. I'd say how we embed and integrate is important.
Yeah. I agree. The integration element is so important. The relationships we build is really key. I think so. From the thinking about the 10-year plan ambitions and what you've outlined there, to the need for certain skill sets and that, how do you think the ambitions support or ensure continuous professional development for hospital pharmacy teams?
I don't know if they do, to be honest. and again, I think whatever they say, unless specific and targeted money follows it, for instance, it will still be left to the local understanding of the need to develop people and invest in CPD. So, for instance, one of the biggest changes I made was growing our education budget, because ultimately, yes, we play an important part in our teams, but we have got to develop people we've got to invest a huge amount in development. There's a very clear return on investment on that. It says all the right thing. And to be honest, pharmacy and our reforms of the undergraduates, for instance, program are very much in line with where the 10-year plan is taking us on the long-term plan before this. But again, it's that you have to have the local will of leaders at local level to make that happen. To recognize the need, for instance, for protected study time.
Yeah.
It's all good and fine to say that we're investing, but if people are not able to do that without it impacting on their home lives or caring responsibilities, then you're only really, to an extent, paying at face value. So there's something about investing both in the time and the space to develop people, to know that part of their development needs to be, for instance, spending time with other teams and not necessarily doing pharmacy work. They come back a more rounded healthcare professional. Yes, you may have lost a couple of hours here or there, but what you get is a more rounded healthcare professional. So playing the long game in terms of staff development is important.
I think so, right. It's interesting the point you made about one of the big key steps you made was in growing the education training budget. And it's interesting comparison when you look at a lot of things in business. When we get tough economic times, typically education, learning, development budgets tend to be one of the first things to go. So actually, it's a really key point. It's that return on investment and the value of fully rounded teams is so important. I think
on there actually, just to make a point about like return on investment, I've forgotten where I saw there's a figure for the cost to onboard a new member of staff, and it's who earns above, and it's somewhere in the region of 25,000. So there's a very clear economic case in investing in your people. And again, another thing that I saw is that you either earn or learn, ideally one, but if not both, leave. and so if you don't invest in developing your staff, you can't then wonder why you don't have any staff to develop.
Very true. Yeah, it's I think probably quite a good link to turnover, and then challenges that brings in itself. Yeah, very good point. That was very very key point. That. Just thinking about the after 3 shifts in the plan. Yeah. How do you think then hospital sector and hospital pharmacy can be part of and contribute to those 3 shifts?
Oh, I'd say what are they? Analog to digital, treatment to prevention. What's the third one? Acute to community.
Yeah.
To be honest, you come back to that spirit of collaboration. We are already set. Pharmacy as a collective has a level of clinical estate, for instance, the community pharmacy gives us, plus general practice for everything we do in here. So already a very trusted profession, already have, already the most accessible healthcare professionals. And so I think in terms of presence and spread, we're already, which is one of the key strategic advantages to trying to deliver any sort of healthcare. We're already quite well set. So, I think in terms of what hospital could do, we could do better by working better with others. We could do better by being more willing to spread the resources that we have across other sectors. Because at the end of the day, and one example I once used, it might be a bit out there, but more of us should do it, is pharmacy first has been a generational change in how the public access healthcare through, and it's fantastic for us to have this opportunity. Maybe more acute trusts should have more of their staff rotating community pharmacies, helping the supplier, helping the provision of that service, because ultimately by doing that, patients don't come into acute trusts, don't come to urgent and treatment care centers. And yes, there might be disenablers such as how our contracts work, MOU, memorandums of understanding, data sharing agreements and all that. But I genuinely believe that where there's a will, there's a way. But I think behind that, there needs to be a very clear vision for what it is that we're trying to achieve. And, one of the things I am most passionate about is driving down the silo of the mentality silos between the different sectors. And, I think that we need to look at how we provide services together better. So in terms of digital to analog, again, some analog to digital even, some of the many of those things are already there. I think, again, one of our key limitations is the pipeline of people we have coming into this space who truly understand what is possible here. Often our digital capability goes as far as finding what we need to find to justify our existing worldview in terms of data. And let's be honest, many of us are scared of data. But that's where transformation sits if you want to really leverage what you have. So, again, I think that we need to do better to build the pool of staff or the pool of people who can be effective in this space. So that, they're not the self-selecting person who happens to like coding or gadgets that happen to get into that. We're building proper pools. And I think more importantly, we're diversifying those pools. So, I know there is absolutely a shortage of staff from a global majority in digital and informatics roles. That affects how we design those, if you like, those new digital pathways. So we need to be cognizant of that, and how we like cultural competency and how we build equality, ethnic equity or equity of opportunity really in these spaces is really important.
Yeah, that's really so important, and the inclusivity, diversity in our workforce and equality are really important measures. Equality patients, but actually how we treat each other as professionals is so important. I fully agree. You mentioned obviously some key bits there around technology, digital. Is what are the current challenges facing implementation of new technology in the hospital pharmacy world?
Money would be one, cold hard cash, and you can never get away from that. And a clear, there's not, but I say the cash comes and goes. Let's be honest. Once in a while, one of our biggest complaints is that it shows up in February and you have to spend it by March, and we're not prepared. But it happens so frequently that that's probably going to happen at some point. So I think there is something about having a clear vision, and again, as a collective, as a system, and what are the milestones you need to. Because part of delivering against the strategy is being able to achieve the small wins and share the small wins, which give your stakeholders confidence in what you're doing. And often I think we're guilty of seeing it as all or nothing, that we have this vision, but nobody's giving us any money, so we're not going to bother. So whereas with digital transformation, there is something about being clear about what are the small milestones. If we don't have the money for the big tech now, it's part of what we need to do to start showing that we're improving digital literacy. It's part of what we're showing people how to use, I don't know, Copilot on Microsoft Teams and Gen AI to start to start changing our processes. So I think there are small wins in there that are possible without cash. I think so I've mentioned cash. I've mentioned previously how well we work with other professions to really design change. The worst thing you can do, in my opinion, is plump the new tech in there and ask people to use it. The amount of time you need to take into co-design, supporting training, understanding what good looks like, what good enough looks like, rather than setting people up to fail. That's what gives you the long-term return and the relationships. And I think on the other end of that, what do we do with the data that this gives us? Because all of a sudden you become data rich. Huge grounds for research and quality improvement. And I think we need to become a lot stronger in that space because, again, pharmacy as a profession, wherever we are, we tend to be quite data rich. How do we use that data better? Now, whether that's data is gold, let's be honest. Whether that's in how we improve, whether that's in how we do research, whether that's in how we build relationships with other industries, we need to do better with what we have.
Yeah, definitely. That's a really good point there. I think being data rich and probably intelligence poor, because I say it's how we use that data. That's the importance of it. But that's really a good point there. Just thinking about the medicine supply chain. What strategies are in place to manage that effectively when hospital pharmacy services? I know it's a big.
And I wish I could pretend to be an expert here, but I'm really not, and there are much cleverer people. So I'm aware that we are part of various regional supply frameworks. I suppose what I am a lot more aware of is some of the risks and the challenges on the patient-facing side, because obviously medicine shortages affect our ability to influence what packaging looks like, for instance. So in terms of there are quite a few challenges, and this is where I see data and automation coming in and having a part to play, because if we have no control over what packaging looks like coming in, what you need is something on the patient side that stops you giving the wrong thing. And so we've had some really good experiences with automation here that I feel are replicable. But in terms of the what was the first bit of the question? Sorry, Stephen.
No, so the strategy, that's really helpful. There's some of the strategies
Yeah.
around managing the supply chain effectively.
Have the right people, train the right people, train the right people, and I think that there are bits of this, and I think we all know that exiting the EU played a part in this that reduced, if you like, our security in this space. And I really do think here it comes back to how do you equip your people to support you through change? How do you have a how do we? One of my challenges to, for instance, procurement teams are what should, other than you just have to be there to experience it, how do we very deliberately develop people in that procurement space? And then obviously, like, we've got some very, very clever and capable pharmacy teams on the patient side supporting guideline change and responding to shortages. So probably a mixture. Ultimately, again, I'd love to see more of this supply happening outside of our pharmacy walls, outside of our hospital pharmacy walls. And so I'd like to see more investment into home care, into direct to patient supplies, because that is often the safest place for people to get their care. So if everyone else is doing that, we should be pushing more into that space.
That makes a lot of sense. And what innovations are being introduced to enhance medicine's optimization, decision making in hospital settings?
Oh, okay. Again, very, very broad question. So, I think as more and more of us deploy electronic prescribing systems, and we're moving to joint electronic patient records and all that, given the pressures on our teams, clinical prioritization is a huge, is an opportunity. There will be a proportion of patients for whom a pharmacy visit adds no value to their day on some days. And so, in effect, how do we ensure that we're not oversupplying in certain areas at the expense of others? So that's one area. And I think there have been quite a few tools developed. The challenge there comes in as the acuity of patients, the thresholds for deeming someone high risk, for instance. So the acuity of patients, as that goes up and up and up, all of a sudden, every single patient on your books is high risk. So if everyone's high risk, no one's high risk. So that would be the one that I'm most aware of. But there are loads, and I've seen quite recently, for instance, some really good work in using self-support AI to support staff to access policies better. So someone asks, I don't know, how do I dispose of this type of medicine into an AI app? And it tells you where in the policy it is. So there is something about the role that we can play in if you like, designing products, if you like, designing things that other staff use better. And, that's, in effect, for me, medicine's optimization is what happens when we're not in the room.
Yeah.
Because the days of being the safety nets are probably gone. Not probably gone, that's the wrong thing. Of being solely the final safety net are gone. And we need to, I think where we need to get better is designing things so we don't have to be there for things to be safe.
Yeah.
And so yeah, the role of the pharmacist and the pharmacy technician must change to, basically designing what works best for the people who deliver most of that direct care.
Yeah, no, I understand that. It does have the influence and the input into the systems and the digital tools and things that help make it work. So when we're not there, it continues.
And part of that is knowing how to let go.
Yeah.
And which is not going to be easy for many people.
Very much a challenge.
In your typical hospital service, even if you have a 7-day service, there will still be many hours of the day where you're not there, where many things can go wrong.
Yeah,
and
definitely.
Yeah,
that makes a lot of sense. And just thinking about personalised medicine, so how are hospital pharmacies adapting to the growing demand for personalised medicine that's been developed in this area?
Again, this is probably very variable. And this, if I was going to make a general commentary on pharmacy, I don't think there is enough of a baseline understanding of what the opportunities are here. So I think hospitals are using a lot more by way of personalized medicine, especially in oncology, hematology, for instance, than the rest. But what I also don't feel there is as good an understanding as we should have at this point of what the opportunities are and how do we start. Our default thinking when we start to look at new services is how we embed personalized medicine. And I don't think we're there. And I don't think we're there yet. So you'll probably find really good examples here and there that are fantastic for one publication or the other. The test then becomes, should I be able to get that standard of personalization at this small district general hospital and go half an hour down the road and expect the same? And often you'll find that's not the case. But nobody is holding us, nobody is holding us to account for that level of for unwanted variation yet. So I think there is a way to go. As with many things, I think we need to put more effort into building a baseline understanding so that you're not expecting, so more of us have the skills to go there and start redesigning services with that in mind.
And appreciate a lot. Yeah, it's that consistency approach, isn't it? And particularly things like pharmacogenomics coming more prevalent, more the norm. How we make that the baseline, everyone understands, and then that's become an expectation, not the unusual, magical thing. So that makes a lot of sense.
Yeah, we have looking at our trainees, foundation pharmacists coming into the workforce now. They will have had a lot more access and insight into this than anyone in the workforce would have had. So they're bringing a lot of knowledge in here. How do we give them a voice as early as possible to actually use the new knowledge that they're bringing in here?
That makes sense. No, that's very good.
And not just be quiet and go and do what we've always done in here.
Yeah, not go and hide in the back and count the tablets.
Yeah,
it's really one point, three key points. And just you've mentioned quite a bit around collaboration, working together. So, in what ways then can hospital pharmacies contribute to system-wide healthcare reforms?
Oh, in lots of ways. First of all, make sure you're in the room, and I think so. Again, you'll be aware there are many cases in which that's the case. I think hospital pharmacy brings a lot of expertise to the room. I think our biggest strength should be making sure that other voices are in the room as well. And I think recognizing, whether we want to admit it or not, some of the conditions that, in terms of access to resource now, whether that's training and education capacity, for instance, there's probably more in this space than your typical pharmacist in a community pharmacy setting or a general practice might get. So I think our bigger role really is in ensuring inclusion, ensuring there are other voices at the table, and having a willingness to change.
Yeah.
So, the most effective thing we can do is design services that mean that we're not needed, and which is going to have to be quite a big cultural shift.
Yeah, definitely. That's a very good point. That, and then you have mentioned about an example of pharmacy fair. So, how do you think hospital pharmacy can better collaborate with community pharmacies to ensure continuity of care and some help some of the shifts?
Yeah, so I think a lot of that links to the digital agenda, which, as I mentioned, a lot of more and more hospital pharmacies. I'm pretty sure that's one of the things in there by 2013, the 10-year plan, about having electronic prescribing systems. Yeah. One of our really big successes here, for instance, was in integrating the pharmacy first referral with our electronic prescribing, like the MedsRec process. And our referrals jumped from 75, 80 a month to 700, 800 a month. So there is something we can do in the space, and as more and more of us move there, as long as into that electronic prescribing space, as long as we have it front and center in our minds, that part of what we need to do is A, make sure the right referrals are going through, but B, integrate our systems so that those happen automatically. even if the percentage of action referral stays the same, what that will mean, therefore, is the actual numbers of patients who have had their transfer of care improved will go up. So again, be willing to be in this space. One of the other things that we are looking to, we've actually trialed already, is referrals from urgent care as well. So I think it's extremely important that we all do our part really to understand how we can support pharmacy first. As I mentioned earlier, it's generational. It's, when you've had so far for 80 years, odd years of the NHS, when you're ill, you go to your general practice. Now, I'm not saying that we are here to replace anyone, not at all.
No.
What we're here is to give patient choice. And, I think it's huge for our profession, and we all have to absolutely get behind. Community pharmacists are very, very, very trusted. Most pharmacists will end up in will work in a community pharmacy. And community pharmacy is absolutely the face of pharmacy. So, I don't think any vision of this future is possible without a sustainable community pharmacy sector.
No, I think it's really, really, very true. And I think, as you've outlined there, it's that the relationship approach. There's some fantastic examples there of referring into pharmacy first and that collaborative working approach. And as you say, we're not trying to replace anyone, but there's a great opportunity to make best use of the right healthcare professional at the right time, and being taken for minor illness and things that don't have to go to a GP, or certainly don't have to turn up an A&E. Let the community pharmacy be the front door, and we can support that process. It lets you focus on the complicated patients that need to be in your setting. GPs complicated patients that need to be in their setting, and we can manage patients better and get better access. So I think that's a really fantastic example of what you said. It's really helpful and great insight. I think finally,
and there I'd say actually it doing this consistently and as almost like taking a one profession view to supporting this builds the foundations for all the other things we think are possible through community farms. If anyone gets me in a room talking about what I think is possible, like basically, why are we delivering our patient services from community pharmacy? True. There's no reason that we can't. So I think we can be as absolutely ambitious in this space as we need to. However, we absolutely do need to support each other.
Definitely, that's a great message. I think it's really key. We need to support each other, and if we work collectively together, then effectively the sky's the limit, isn't it? And what we could achieve. So finally, in this series, we've asked each of our previous guests to ask a question for the next guest. So last week, Shilpa asked, as part of the 10-year plan, there's an ambition to obviously to move from hospital to community. So what does that look like for you?
Okay, sorry, could you ask me that question again?
Yes, certainly. So Shilpa's question was, obviously, as part of the 10-year plan, one of the key ambition shifts is to move care from hospital to community. So what would that look like for you as a shift becomes realised?
Again, I'll probably look at that through, through the lens of which I see the world, which is how do we equip our workforce to do that? And in my view, I think we'll have achieved it when you can go into a community pharmacy and meet an advanced or consultant pharmacist in that space who will enroll you on a clinical trial. That pharmacist will have, or pharmacy technician will have, full access to both the acute and community space, access to all the professionals that they need to, and you can be fully managed through that specialist clinical trial from your community pharmacy space close to your home. And you will never in that time feel that you don't have the ability to ask for help, or that you have to call a helpline and someone gets back to you within 48 hours. And I think those things are all possible already. What we need is a collective will to make it happen.
Yeah, that's a really great vision, I think. And as you say, it goes back to your point, doesn't it, of if they got their expertise, specialism in secondary care, how can we then share that and utilise that to help deliver in the community? And that's a fantastic example. Right?
And that's the thing. I'd put a slight correction in there. We have that expertise everywhere. We have that expertise already across the sectors. What we don't have is the connectivity between the sectors and that clear vision of not just the vision, but what are the milestones to get to that vision. there are some real success stories in terms of system working out there. There's, as you can imagine, lots of different levels of maturity across different. We just need to raise the baseline year on year on year.
Definitely, that's a great position to be in. So next week we'll be talking to Sarah Trust, who's a senior clinical pharmacist. She's a PCN and system leader, and she's an advocate for safer prescribing and patient-centered care. So, Uzo, what would you like me to ask Sarah?
Oh, I don't know. Right. What's the one thing you would change to make pharmacy more influential in primary care?
That's a really great question. I think I'll put that to Sarah next week. That's a fantastic question to get that influence and piece. I think you say about the leadership and influence, and that'd be really great to get her insights on that from a primary care perspective. So, fortunately, that's all that we have time for this week. But Uzo, is there anything final thoughts you'd like to add?
Oh no, I could get talking all day, to be perfectly honest. And I think for me and personally, some of the work that we're doing here, I think we need to look at how we start to develop the new generation of foundation pharmacists and trainees coming in, and how we equip them quite early to build networks, to work better with other industries, to work better with other sectors, to understand healthcare in its broadest sense. Because I think, and to be honest, it's quite widely thought that we're, the days of our effectiveness being grounded in how much we knew and being the cleverest person in the room in terms of medicines are gone. And more and more it's about being system architects. So, being able to design the tools to, in effect, enable and empower others to deliver the best for our patients. And that there's going to need to be a fundamental shift in both how we see ourselves and, how we communicate our vision for the future. So I'm very passionate about how we develop our trainees of the future, and some of the work that we've done here around a single employer model for pharmacy trainees is very, very much with that in mind. And it's been quite innovative, and we're really proud of it. So I think our early career, well, to be honest, all of our people are our future, and I think we need to start designing now for that future in 10 years.
That's a great position. I think it's a really important position we've got, and the duty we've got to our newly qualified and foundation training colleagues, early career colleagues, and also developing the leaders of the future. That's a really important responsibility of all to take on as system leaders. That's a fantastic position to end on. So again, I'd really like to thank you for coming on this episode, Uzo. We appreciate your time and your really valuable. So thank you for that. And just remember, listeners, to follow us on social media. And I'll see you again next week when we speak to Sarah Trust. Thank you for joining us today, and hope you've enjoyed it.
Thank you. Thanks, Steve.